Thank you for joining me for this short talk entitled Breast Block Description that was delivered at the World Congress in Regional Anaesthesia in Paris in September 2023. Here are my disclosures, and all I wanted to point out is please, if you like the videos, do like and subscribe to the channel, and also take the chance to check out the Block It Like It's Hot podcast I do with Jeff Gadsden, available on all podcast streaming platforms. So what am I going to cover? I'm going to cover a brief recap on the block choices by looking at the anatomy that's relevant. We're also going to be thinking how we should pick our blocks. How do we choose which blocks are useful for breast surgery? And I'll ask the question, is there one block to rule them all? And the next slide kind of gives away the answer. I'm going to tell you how to get the most out of your paravertebral block. And lastly, we'll talk about some complications and alternatives. So if we revisit the block choices that are available to you, we need to have a look at the anatomy, and you'll remember that there is dermatomal coverage from the intercostal nerves, but in addition to that, there are those individual nerves that may be relevant for your surgical incision. The supraclavicular nerves, the intercostal nerves, both the anterior cutaneous branch and the lateral cutaneous branch. You've then got the intercostobrachial and the medial brachial cutaneous nerves, and then again, the long thoracic and medial and lateral pectoral nerves. So with this information, can we then think about the nerve supply of those different areas in terms of what blocks would aim to cover them? So we clearly got the supraclavicular nerves, the parasternal intercostal nerve block and the interpectoral pectus serratus, the serratus anterior and the paravertebral, and you can look at the different territories that those blocks would cover and how they relate back to the anatomy. So as you can see here, we've got a lot of blocks. What I'm going to do is try and break them down into different areas. So we're going to start off with the paravertebral, and I'm going to be using some of the terminology that comes from this nomenclature paper. Again, a group of American, European experts got together and came up with a consensus guideline as to what we should be talking about when we're describing these blocks, because a whole multitude of blocks are being described. So we can start off, we've got the paravertebral, that's relatively straightforward. Then we've got the paraspinal plane blocks, the anterolateral chest wall blocks, and the anteromedial chest wall blocks. So let's have a look at those in a bit more detail. The paraspinal plane blocks, examples of which are the erector spinae plane, the retrolamina, and some many others. And then we've got the intertransverse process block that was formerly known as the MTP, or midpoint between transverse process and pleura. Then got the anterolateral chest wall blocks, that's the serratus anterior plane, the pectoserratus plane, and the interpectoral plane blocks. And the anteromedial chest wall blocks have now been consolidated into the parasternal intercostal plane. So you can now map out the areas of the chest wall and divide those blocks according to where they originate from. But let's have a look at that in terms of an overlay over a cross-section of the thorax. So here's where the paravertebral block would be placed. The ESP, retrolamina, and intertransverse process blocks will be placed here. This is where you can see the pectus serratus, interpectoral plane, and the deep and superficial serratus anterior plane blocks will be placed. And again, last but not least, we've got the parasternal intercostal plane, both superficial and deep variants. So we've got a lot of choice now. How do we pick our blocks? And I'll refer you back to those general block questions, or PowerPoints as I call them, that you need to think about when you're performing any block. The first question you will need to ask is, what block gives the best analgesia or anesthesia? Having identified that, you need to think, does the risk-benefit ratio of that block favour using that particular technique? When you've decided what block you would like to perform and you think the risk-benefit ratio favours doing that, are there any patient factors that will alter your decision? Altered anatomy, anticoagulation status, infection status, or pain or respiratory issues? Then you've got to think about whether you have the skill or capability to put it in yourself. Is the surgeon happy for you to place those blocks? And then the last question you've got to ask about is, what happens if I do nothing? Are there any alternative strategies? Now, in addition, for breast surgery, I have a few more questions. What I also like to consider are, what's the pain trajectory of that particular surgery? A mastectomy will have a pain trajectory that lasts, say, maybe 48 hours, whereas a lumpectomy that may only be sore for 24 hours. I want to think, is the muscle going to be involved? If the muscle's going to be involved, it may mean that I need to make sure I cover the pectoral nerves, for example. I also want to think about the zone of provocation. I need to think about where the incision is going to be and whether the block I'm proposing will cover where that incision will going to be. And lastly, I want to consider whether the axilla is going to be involved. Because if the axilla is going to be involved, it may mean that I need to think about altering the level of the block I'm going to be citing or adding additional blocks in. So now, if we're going to decide what block gives the best analgesia or anaesthesia, well, we have a gynecologist to thank for that. And the gynecologist I'm referring to is Hugo Selheim of Leipzig in Germany. He pioneered the particular technique I'm talking about in 1905 when he used it for abdominal analgesia, and then subsequent to that it's been used by a whole host of people. It was popularized by Easton and Wyatt. I am, of course, talking about the paravertebral block, which I think is the king of blocks, and I'd like to give a shout out to two people that have helped inspire me when it comes to delivering this block, John McDonnell and Manoj Karmarkar. John taught me how to do the block, and Manoj has considered many different modifications and different ways to think about the block, so I'd like to thank them both. But why is the paravertebral block the best for breast? Why do I think it's the best? Well, I'll tell you. If you have a look at the chest wall coverage delivered by all of the different blocks, and we have a look over here at this slightly complicated looking table, well, if I take out the brachial plexus component, because that's only really covered by the interpectoral and pectus serratus, and then just focus on the intercostal nerves, you can see that the block that gives you the most consistent coverage is the paravertebral block. And we also know that the paravertebral block has been demonstrated to reduce acute pain, to reduce chronic pain, to show a reduction in opioid requirements. It's a reliable technique when you can perform it. It's associated with increased ambulation, enhanced quality of recovery, reduced nausea and vomiting, and what I'm most interested about is the fact it can be used as an alternative to general anaesthetic. Now, there are a whole host of papers that might show you that evidence, but I've just highlighted a few papers here via these QR codes. If you were to scan them individually, they would take you to a few review articles and some papers that show you why the paravertebral block is the best, in my opinion. Now, what about location of surgery? Does the location of surgery change or alter what block you might choose? Well, if we consider a wide local excision or a lumpectomy, so a relatively minor breast surgery, paravertebral block probably still gives you the best analgesia when we look at that zone of coverage that we talked about. But can you always justify the risk of a paravertebral block versus the benefit that you may get? In some cases, when you consider patient factors, actually it may be that they really would benefit from having dense analgesia, and therefore you would do it. Whereas there may be a young, fit, healthy patient that's relatively robust having a small lumpectomy, and you say, well, actually, the risk-benefit ratio isn't really in favour of the paravertebral block. You also need to consider the staff skill mix of the person who's going to be performing the block, as well as time and logistics. But there are some alternatives to doing a paravertebral block. It may be that you could manage with just local anaesthetic infiltration, or maybe you could do some location-dependent blocks. What do I mean by that? Well, if the incision is medial to the nipple, between the sternum and the nipple, then doing a lateral cutaneous block won't help you. So at that stage, you might consider doing a parasternal intercostal plane block to get that anterior cutaneous branch coverage. If it's lateral, you then may be considering doing an interpectoral or pectus serratus blocks or a serratus anterior, depending upon how deep the surgery is going to be and what tissue is involved. But you could also consider maybe doing one of those paraspinal plane blocks. You might want to do an ESP block or an intertransverse process block. When it comes to mastectomy plus or minus a reconstruction, then probably the paravertebral is going to provide the best analgesia, and it's likely to be beneficial because of that zone of coverage that you get. Again, you might want to consider patient factors. Is there anything that would make you think, well, actually it's not safe to perform that block? And again, the staff skill mix. It may be that whilst you think paravertebral block would be the best block to perform for a mastectomy, you may not be comfortable or confident in which to perform those blocks. So are there alternatives? Well, you could again do a combination of blocks. You could do the medial chest wall coverage by doing the parasternal intercostal plane blocks, and you may choose to add in serratus anterior plane or pectus serratus to get the lateral coverage. But again, if you wanted to, you could consider doing the paraspinal plane blocks, the ESP or the ITP here. And worst case scenario, there is always the option of either local anesthesia infiltration or surgically administered serratus plane, pectus serratus plane. I think, however, that the paravertebral seems to be the most consistent. So is it the one block to rule them all? Well, I think so. But the question is, why aren't more people doing paravertebrals? It may be because they don't feel confident performing the block. It may be because they consider the risk profile to be so high. Or it may be because it's difficult to do, or it's difficult to insert in that particular patient. And it may even be because when they say to a patient, I'd like to stick a needle near your spine, the patient says no and the patient is not happy with that. It's clear to say that the paravertebral is not an entry-level block. But how can we get the most out of our paravertebrals if we're going to start to cite them? So I'm going to take you through some of the paravertebral points. Well, I think it's really important that we understand sonoanatomy. Again, we've got two particular probe positions. We've got the paramedian sagittal scan probe position, or we've got the transverse scan. And the anatomy you identify with each of those probe positions is slightly different. And you can see here with these ultrasound images and these color overlays, you can hopefully appreciate those different anatomical structures. So once you've decided which probe position you're going to use, we then got to talk about actually doing the block. And it's important before you do the block, you take consent for the block, involving talking about the risks and the benefits. You get full monitoring and intravenous access, as well as using the appropriate amount of sedation. Because one of the things that can happen when you're performing a block is you could have the patient suddenly have a vasovagal and collapse, as is shown in the video here. So you need to be prepared for that. And it may be that you alter the position you perform the block in to try and reduce the risk of those type of complications. So when I first started doing the block, as you'd see here, I used to do it with the patient in the sitting position, and that was fine for the majority of blocks, certainly for blocks that didn't take time. But after a while, the practitioner can get fatigued, especially when the arm is away from the body or when you're holding your arms up at shoulder height. So I then moved to taking the patients into the semi-prone position. However, sometimes trying to explain to the patient how to lie on their side and then flop over became a little bit difficult. So now, most of the time, when I'm performing the block, I get the patients fully prone. And the advantage of doing that with patients before they go off to sleep is it's easy to get them to lay on their front. They're then nice and stable. You can use a decent amount of sedation, get them comfortable, and everything is nice and stable. So what are my tips for success? Well, let's start off here with the probe in a paramedian sagittal orientation, far away over the ribs. So I know that the bones that I'm looking at are the ribs, and I know deep the ribs I see the pleura. And then slide from lateral towards the midline, and you see the ribs go deeper and they get replaced by these rectangular shaped transverse processes. With a slight bit of tilt, you can then begin to appreciate the pleura deep to them, and then see the green line there, which is the superior costotransverse ligament. If you do a transverse scan, I start from the midline over the spinous process from the level above, scan laterally, I see a transverse process meeting the rib, and then I drop down into the intercostal space. Now on the left hand side of the screen I've got a transverse process, on the right hand side of the screen I've got pleura, and then I can see the internal intercostal membrane at this level. So once you've identified those solid anatomical landmarks, you're then ready to needle. How are we going to needle? Well, depending upon which probe position we've got, we can either choose to needle in plane or out of plane. Now clearly outer plane needling takes a smaller needle journey through the skin. You get down to your endpoint very quickly, but there is the risk that the needle is not visualized. You don't see the needle tip and you end up inserting the needle deeper than you want to. And for that reason, I tend to favor in-plane needling. And it's nice to be able to appreciate what your needle is doing in real time. And this QR code will take you to a paper that sort of discusses these blocks in a little bit more detail. But you can see here on the left hand side of the screen, needling in plane from caudad to cephalad, and you can appreciate where that needle is passing in relation to the skeleton to get down to the endpoint. But I have now moved across now to doing transverse in-plane needling, because with the patient in the prone position this is slightly easier to do, and I find that novices find this an easier technique to perform. In patients with a high body mass index, it's actually easier to perform this particular technique, but be careful because you are directing a needle towards the central neuraxis. Now, having got everything ready to rock and roll, what needle are you going to use? Well, I think again you've got two choices. You can use a facet tip needle or a TUI tip needle, and I prefer to use a TUI needle mainly because you then haven't got that sharp point of the needle directly advancing towards the pleura. And the Huber tip of that TUI needle gives you that little safety margin so you can pop into the fascial plane and you know you're not directed directly towards the pleura. Now, in terms of picking the right level, I think you've got two options. You can either do one single level injection using about 20 cc's of local anaesthetic at T2 or T3, or you can do 4 to 5 injections throughout the chest wall, sort of 4 to 5 mils of local anaesthetic at 4 or 5 places. But my preference is to use that single level injection. And why is that? Well, there's some historical papers that show the benefit, but there's a more recent paper looking at ultrasound guided paravertebral blocks, and it showed that the dermatomal coverage you get from a single level is the same as the dermatomal level coverage you get from a 5-level block. So why do 5 needle sticks when you can achieve the same analgesic effect with a single level? And that's what I do. Now, are there any more tips for success that I can give you? Well, there is one. Let's have a look here. Now, we're going to imagine doing a paramedian sagittal scan, and we're going to start by scanning over the ribs and aim to get towards a transverse process. So we'll go over towards the transverse process, and sometimes what happens is you get an image where you've got 2 transverse processes on the screen, and as you're inserting the needle, you hit the caudad transverse process. So to minimize that risk, you can oblique the probe here so that the caudad bony landmark you come up to is slightly lower. That's the rib now, and it makes it easier for you to get in. But you must be careful when rotating the probe. You don't want to rotate the probe like this, so the superior part of the probe comes towards the lamina, because then you're needling towards the central neuraxis. Instead, once you've got to the transverse processes, what you want to do is to pivot on the Keflad part of the probe, so that way the Keflad part of the probe stays where it is, and when you needle in plane, you make sure you're still targeted towards the paravertebral space, but from a safe angle. What does it look like in reality when you do the blocks? Well, here are 2 block videos running back to back. You can see the needle coming in plane on the left hand side of the screen. We're going to hydrodissect our way through the internal intercostal membrane and then watch that pleura drop down. You'll see it's almost there. We're about to pop through the internal intercostal membrane, and there's a pleura drop. And the right hand side of the screen, you can see the needle just approaching the superior costotransverse ligament, and then as we get into the right place, you see that pleura drop out of the way. Hopefully nice and clearly demonstrated there. Well, are there any complications and alternatives? Well, yes, there are. What are the complications and alternatives talked about for the paravertebral block? Well, the biggest, most feared one is, of course, the pneumothorax. I'm going to show you that the true incidence of that is probably not as high as we think. Also got a failed or patchy block, hypotension or sympathectomy. Now, sympathectomy can be an advantage with paravertebral blocks. There is, of course, the risk of local anesthetic systemic toxicity and many more. But let's focus on pneumothorax. There are 2 papers I'd like to show you here, which is using ultrasound-guided paravertebral blocks with large numbers of blocks. And in the first paper, they had 0 pneumothoraces out of nearly 1,500 blocks. And the lower paper here, they had just over 2,000 blocks, and there were 2 pneumothoraces that were picked up on chest x-ray, but did not require advanced treatment. So actually, maybe the risk is not quite as high as we thought. And those QR codes will take you to those original papers. I do want to highlight here the alternatives looking at this whole concept of paravertebral by proxy, saying, well, you know what? Actually, maybe you don't actually need to be in the paravertebral space, so deep to the superior costotransverse ligament, in order to get a successful paravertebral block. And that's where this whole concept of the MTP, or now known as the intertransverse process plane block, came from. We noticed that local anesthetic deposited behind the superior costotransverse ligament in the intertransverse tissue complex still resulted in analgesia and pleural depression. And there have been a couple of other papers and discussion points that will expand your knowledge if you look at those QR codes. So I want you to imagine now, you take a group of anaesthetists and you ask them about blocks, and you say to them, look, how many of you would be happy to perform a paravertebral block? And if you ask people, maybe not so many will say they're happy to do it. You say how many would be happy to do an ITP block, or maybe a few more. And then if you end up by saying, well, how many of you would be happy to come up here to the erector spinae plane, you'll find you've got a larger number of people that are prepared to do that. And with that knowledge that more people are happy to do the superficial blocks, you can teach the paravertebral block by skill progression. get people doing ESP blocks, get a bit more comfortable to go deeper, and then when they've got that confident, go right the way down to the paravertebral space. So each time they gain their confidence, they can take their skill progression a little bit further. So what about this rectospinal plane block? Well, there's a recent cadaveric study that evaluated two approaches. It evaluated a medial needle placement where you identified the transverse process and inserted your needle relatively medial along that transverse process, and they compared that to a needle placement between the two transverse processes. And when they looked at these two techniques, what they discovered was the erectospinal plane block that was placed between the transverse processes spread more extensively than the needle endpoint that was medial on the transverse process. And actually, when they evaluated their anterior spread, the in-between needle placement, so needle placed between transverse processes, actually got much more anterior spread, and you can see that clearly identified on the diagram here. So when we're thinking about the rectospinal plane block, it may be that a successful ESP block relies on deeper needle placement, a little bit more like an ITP injection. Can I back that up with any more studies? Well, actually, yes. There's another recent study that was only published in August 2023. They took 15 cadavers, and in those 15 cadavers, they did 5 ESP blocks, 5 ITP blocks, and 5 paravertebral blocks, and they injected with local anesthetic and methylene blue. Now, if you have a look at the spread that they got from the ESP block, they definitely got very good coverage of the dorsal rami and the erectospinal muscle, but they didn't get any spread at all to the paravertebral space or to the ventral rami. When they looked at the paravertebral blocks, they got coverage of the dorsal rami, they got obviously coverage of the paravertebral space, the ventral rami, but they didn't get any coverage down in the ES muscles. But when it came to the ITP block, they got dorsal rami coverage, which you'd expect because you're in that vicinity, and they got coverage around the erectospinal muscle, but they also got paravertebral and ventral rami spread. So it looks like the ITP block may be that compromise between doing a paravertebral and then doing an ESP, which may not get as deep as you want. So it may be that actually the ITP is more reliable than the erectospinal plane block for breast surgery. So let's summarize. I would like to tell you that I think the paravertebral is best for breast, and the reason for that is there's an established strong evidence base for it. We've got extensive chest wall coverage. A single injection is usually sufficient. It has a low risk profile. It's not as risky as we think, but it is not a beginner's block. And we also know that there are proxy techniques, so paravertebral by proxy techniques that exist, such as the ESP and the ITP, that can help you on your journey. But for now, there's no doubt in my mind that the paravertebral is the king of blocks. If you've enjoyed listening to this video, please do check out the rest of the videos on my YouTube channel, and also check out the podcast Block It Like It's Hot, which is available on all streaming platforms. Thank you very much.